Thank you for having me. I'm Theresa Williamson. I'm a neurosurgeon at Rhode Island Hospital. When I got this topic, I really thought about a specific subset of patients that are referred to me. I am deformity trained, but I also do a lot of minimally invasive and endoscopic spine surgery. And so one of the things that I pride myself on is this ability to kind of treat the whole gamut of our patients. But where this question of when to go big, when not to go big comes in the most is when, my partners who have predominant deformity practices send me the patient with the coronal degenerative curve. We've all seen it. There's a fairly large Cobb angle. There's sometimes, some lateral ascesis, and they say like, this patient has an isolated radiculopathy. Can you just do a decompression at the apex of the curve? Can you just, it's purely L4, it's purely L5. Can you get away with it? And I think as a field, we're still in a place where we're having a tough time answering this question. And so that's what I really want to talk about today. This is a patient that came to me with that exact question. So this is a 65-year-old woman who has osteoporosis, who's had 2 compression fractures treated with kyphoplasty, both of which are at the apex of her curve, L3 and L4. She's got on the MRI, you can see the sagittal on the left side, and then her axial, that's a slice at L4-5 with severe facet arthropathy and foraminal stenosis at L4. And truly, she is bedridden by an L4 radic. Nothing else. She's had transforaminal injections. She's done well for a couple days, then she comes back. And so, she's also Parkinsonian, of course, just to add a little extra to the story. And so, this is actually what I do research in because I care a lot about like this specific patient. This is a patient who, of all their medical problems, their spine is the reason why their quality of life is terrible. And so how do we go about helping this patient meet their goals while also navigating their fears around spine surgery? Often you have patients like this walk into your clinic and you're like, if the first words out of your mouth are T10 to the pelvis, they're like, as quickly as they can get with their lumbar radiculopathy out the door, they're out the door. And often they came to see you because it says MIS on your door or on your white coat. And so we actually studied this. We looked at patients with lumbar spine surgery, particularly elderly patients, and we looked at what are the predictors of them having surgery or not. Because what we found in a large study that we did at MGB in our patient population was actually there was this subset of patients that had severe limitations of quality of life on patient-reported outcomes, didn't get surgery, and then continued to have those poor quality of life outcomes and still be unhappy with their outcome with the other measures that we gave them. So there was this opportunity for intervention, and there was this other group where they actually went and had the big deformity surgery. And we know from some of the studies that have been done that these patients may actually have improvement of quality of life, but what does it take in between? So we interviewed 20 patients. We asked them, in a qualitative survey, what are the reasons why you would or would not have surgery from this group of patients that self-selected away from intervention. And one of the big things was, especially in our elderly patients, not wanting to be a burden on family. So a lot of people didn't necessarily care that they were going to be in pain for a year if they could feel better a year later. But it was like, my kid's a tax attorney, it's tax season. I can't have them out of work, for months taking care of me. And so that's where I think this MIS idea comes in of, okay, well, what if we could do, an endoscopic surgery or something like that? You go home the same day. And, you don't have that huge burden on your family. But I think the reality is if that surgery lasts for 3 weeks, have we actually done that person any favors in the long term? Or should we try to create a system around that person in which they can have the resources they need to get the larger surgery? So that's the soccer player. If you're wondering why there's a soccer player on that, I mentor a lot of women athletes. And this is Emmy's paper that was recently published in the Interventional Journal of Pain. And the reason why we went for a pain journal actually is because often these patients never get to us because they're doing injection after injection after injection, and they're afraid to be, referred to a surgical provider. So we felt like it was important to sort of speak to the larger population of people caring for spine disease. So how do we decide on this, left-sided picture versus this right-sided picture, right? So are we taking this person to the ambulatory surgery center, or are we bringing this person, into the hospital system for a week, months, however long? And so the reason why I share this case, I like to be, I feel like it's good to be vulnerable. My mentors were always vulnerable around their cases. Like, not going to show you the case that went perfectly. And so I decided to go small. I was like, it's an isolated radiculopathy, let's just do a tubular decompression. And I, maybe not the wisest thing right at the apex of the curve. I will accept that judgment. And did a decompression, and she did awesome. I did 2 levels, which is important. I'll show you some data later why that was not such a good idea. But I did 2 levels because I figured, okay, traversing nerve, exiting nerve, it's getting compressed 2 places. Like, I had logic behind what I was doing. So the left is the first. She did awesome for 6 weeks, and she came back exactly the same. Repeated the MRI, still a lot of subfacet stenosis, which, subarticular stenosis, which is not a huge surprise. But it was all isolated to L4-5. So I thought, okay, we could do a segmental fusion. So I did a lateral at 4-5. This time she did better for a few months. At the whole time I'm optimizing her bone health, having conversations with her about the fact that, this surgery we're probably headed down the bigger path. She came back to me, really the same issue. L3-4 had progressively worsened. Those of you who are experienced spine surgeons in the room are like, yeah, I would have told you that a while ago, Theresa, but you weren't there. So, so then, when she came at L3-4, I sent this to my mentors who I was talking about last night and got the, T10 to the pelvis final answer. And so that's what we did. She did great. She's 2 years out now. She's done phenomenally well. She's a nurse. And one of her, sort of comments to me was like, we probably should have just done this right from the beginning. And so I think, what are the indications to go big versus go small right from the beginning in this particular subset of patients? So some of the key predictors of success are lower Cobb angles, less than 20 degrees. She was kind of on the border of that. And then some of the risk factors, which I think are really important. And by the way, these are also risk factors for failing injections. So when I go to the pain meetings and they look at their data, the interventional pain meetings has almost the exact same criteria that comes out of our spine literature. So scoliosis greater than 20 degrees, lateral aesthesis, which she had, sagittal SVA of greater than 7, and then multi-level decompression. So, decompressing more than one level is a risk factor for further surgery and revision. I think some places we can do better as we study this population. I often get asked the question around, okay, but I'm 82, is it better to have the big surgery at 82, or should I try to stave it off until I'm 85? Will I ever be a candidate for it then? We all know people are living longer. I think the longest person alive right now is like 115 or so. So if you're 82, that's a long way to go. And I think thinking about when the timing for a big surgery, how long until they fail, and which MIS approaches are going to offer more success. And then I think from the patient perception standpoint, what is their tolerance of a complication or of a long stay, and how can we help support them through that? Thanks so much.
Thank you.